started having interns here at CWFM, we found that we needed some more specific hands-on coaching while they were in the room. Integrated care is still a fairly new field, and so the interns coming in might not necessarily have had specific experience in this field. So we found it valuable to have someone in the room with them to give them some more concrete feedback on the skills that you might observe in a specific session. So these tools were designed to be used with the interns so that after the session, we could go back through the things that they may have missed in the session or things that they did very well, so that they could help develop a standard skill set. So we designed them to be used with our interns, or behavioral health consultant interns here, but really they could be used with any BHC who is joining the integrated team, whether that's to help them upskill to the specific skills needed in primary care behavioral health, or to check in on a BHC to make sure their skills stay consistent over time. So each of the sections has a space where you can provide a score from 1 to 5. We have a key at the end of each observation form so you can decide what value fits most based on the content they included in that section. Each section will get a score, and then those will be summed at the end so that if there's a possible 25 points, we'll say you got 20 points or 21 points out of 25 at the end. It's really just to provide a more quantifiable way of showing progress over time. So we have two forms. One is for the initial appointment and one is for a follow-up. They're both very similar, but the initial obviously includes the contextual interview, which is when you're really getting to know the patient the first time you've seen them. Now, the way those appointments might have been initiated could be different. So the warm handoff is when a provider in the clinic has identified they would like a BHC to come in on one of the appointments they currently have, and they request that BHC to come now. So it's a same-day access appointment. The scheduled appointment would be a patient who is already on the BHC schedule for that day. And then the cold crash would be when the BHC identifies on a provider's schedule a patient they think could benefit from BHC services, and they initiate the appointment themselves. So during the interview, the observation, what happens is I will go into an intern's clinic with them as they conduct their session, and I will fill out one observation form for that particular patient, and then another observation form if we see a different patient during that clinic. Those scores are then given per appointment. So each patient will have a particular score for how the skills observed during that particular patient's appointment. So in the initial appointment observation, really we're looking first at whether they set up the expectations for the patient about what is included in BHC services. Are they providing all the points of information the patient needs to provide informed consent? And just letting the patient know about things that might happen during a typical BHC session so that, again, those expectations are consistent for what will happen in this appointment and potential follow-up appointments. In the items that you see in the initial intro, which is, do they introduce themselves and any other provider in the room? Do they establish the relationships of the people who might be present with the patient? Really, we are just checking in as, did they do these things at some point? For example, the last one is, did they inform the patient that the cell phones might be used as part of our paging system, as opposed to just having their cell phone there and it go off during the appointment and the patient wondering why that is? So after the intro, they generally proceed to the contextual interview. This is to help the BHC both get their own picture and also provide context for the medical provider about the patient's life, the things that could be impacting this problem, or the things that are going well and aren't impacting whatever problem they're presenting with that day. This form isn't necessarily about teaching them to use the contextual interview. They would have learned that at a different point, but it is about checking in to make sure that they are regularly checking in on all the different parts of the contextual interview. So the contextual interview includes the love, work, play interview, checking in the different parts of the patient's life that one might both provide some protective factors, things that are a strength for them, but also things that could be providing barriers to them getting better or improving with whatever problem they're presenting with. It also includes health behaviors and risk areas. So those are more things like sleep, diet, exercise, that sort of things, whereas love, work, play focus on relationships, their work environment, that sort of thing. So after the contextual interview section, we have a section that looks into more some of the process of how the BHC is interviewing the patient. So we want to know if did they assess the problem, not just asking the patient about the different areas of their life with their relationships, their work environment, but also if they're presenting with anxiety, what sort of symptoms are they experiencing that are related to anxiety? How often? When did this start? That's part of the 3 T's, the utilization of the 3 T's. We also want to know if they assessed ACEs. So it's not just enough to ask, are your parents in your life, but also maybe family history in terms of did they experience abuse as a child? Things that might not necessarily come up in an initial interview, but we know impact their current functioning. We also have a place to calculate the time that it took them to do the contextual interview. We want to know that they are staying true to the primary care behavioral health model and doing these in shortened appointments so that we can meet as many patient needs as possible. The next section really focuses on how the BHC moves through the session, how they build rapport with the patient but continue to keep the session moving so that we can keep it to the shortened time frame that's more common in the primary care behavioral health model. So yes, I want to know, are they able to build rapport with the patient? Do they use words that are at the health literacy of the patient that they're seeing? But I also want to know they don't get bogged down in doing that and that they can move the session along quickly while they're building that rapport. So this section is really focused less on the specific components that they might be asking the patient and more about how they manage that appointment with the patient. So for the intervention and goals, the main thing I'm looking for is whatever the presenting problem was that presented by the patient and the referral provider, are they addressing that with their interventions? Any appointment we walk into could have any varied number of interventions applied, but I want to make sure that they are consciously making good choices to connect whatever the presenting problem with what they decide to do with that patient. One of the things we want to make sure that the BHC or intern is doing is that they are including the patient in the creation of these goals or assigning homework, that we're not just giving them something that we think will help them improve on the problem that they're working on, but that the patient also thinks will help them make progress on whatever they're wanting to address. We do that through and we want them to make small, specific steps. So we make SMART goals with the patient. If the intern is making goals that are much too broad or too big for the patient to be able to accomplish in the next few weeks, then we know that that actually leads to patients becoming discouraged and not following through. So we also want to make sure that they're using the SMART goals. One of the other things that we know helps with patients following through on the plans created in sessions is giving them something written with the goals that they've discussed with the BHC to take with them out of the clinic. So we will want to see that they give them some sort of written handout about the things that have been discussed that day, maybe even the specific goals that they will be following up on. We also want to make sure that they are checking in with the patient that the goals that they've set are feasible for that patient. That goes back to negotiating the goals with the patient, making sure that's a collaborative process. And then the BHC and the patient together will decide if a follow-up is needed. It may be that the patient decides they want to call when they're ready for another session, or they feel that they got everything that they needed in that one session. The last portions of this form really are not part of the scoring process because we more want to make sure that they're just included, but how they look may be a little bit different. So it was difficult to incorporate in the rating system. So at this point, we just want to make sure, are they administering the Duke for each patient, which is a measure of perceived health? And are they communicating with the PCP following the appointment? If they aren't able to directly talk with the PCP, are they sending them a message to give them information about what occurred in that appointment to help inform the care that they will give the patient? The last part, the additional notes. This is where, during the observation process, I will take some notes on what the BHC did particularly well, things I want to highlight that I hope they continue to do, and also areas where maybe they could have some possible improvement. So if they are consistently skipping part of the contextual interview, I will note that in the possible improvement section, just saying, it seems that this is a consistent area that you miss. Maybe remember that for next time. And then also you'll see in that section an area for you to write down what date you reviewed this form with the intern. We hope that you review these forms with the intern at the end of their clinic. The more immediate the feedback seems to be the better. However, not always possible with the pace of PCVH, so there is a space for you to write down when you did that feedback session if it occurred on a different day, and a place for you to record the total points that they earned throughout the observation form. The information that we just reviewed regards specifically the initial observation form. Now we'll cover the follow-up form, and while they're very similar, there are some key differences. First of all, the follow-up form doesn't include the contextual interview or the more specific assessment of the referral problem because it's assumed that that was covered in the first initial session. I should also note that a follow-up appointment may still be this BHC's first time with this patient, but this patient is following up after their first appointment with a BHC somewhere. So for the follow-up, we want to know that they are checking in on the goals that were set during the last appointment, their initial appointment, or a prior follow-up session, and what the progress was, or what got in the way for the patient in making progress on those goals. We want to see that they are negotiating the agenda for that visit, so the patient may come in with a lot of ideas for things that they would want to cover during that session, but because of the limited amount of time, we want to negotiate following up on the things covered in the last session, but also maybe including some of the new problems that the patient is wanting to discuss. So negotiating that with the patient is something we want to make sure that the BHC is doing. The other thing that we want to make sure an intern or BHC is doing if they're doing a follow-up is that they're checking in on any potential suicidal ideations or suicidal behaviors that were noted during that prior session. So those are the main key things you'll see different in the first part of the follow-up form that were not on the initial observation form. On the follow-up form, the potential points that the BHC or intern can earn are less than on the initial. The initial has a possible 25 points available. This form has 15. For the Behavioral Health Consultant Intern Clinic Summary form, what we are looking at here is higher level skills that you might not observe in each individual appointment, but that you might observe over the course of the clinic. It lists 13 different points for which we would like to see some progress from the intern or BHC over the course of their time with us, even though they may not happen in each individual clinic. These 13 points are based on the quarterly evaluations that were created for the National Psychology Training Consortium that each intern gets each quarter, and things that we want to know that they are progressing on as they move towards being independently licensed psychologists. So for example, one of the points is, do they demonstrate flexibility in seeking out warm handoffs? And what I might look for there is, are they scrubbing the schedules of the medical providers when they come in to see potential appointments for the day? Are they accepting the warm handoffs as they come through and managing their time appropriately to take as many warm handoffs as possible? If they're doing very well in that, I'll check the box and then make a note in the bottom section saying, does an excellent job seeking warm handoffs and accepting them as they come. If perhaps it's a point where they could improve, I will do the same thing. Check the box, make a note at the bottom that this is something that they may need to improve on in the future. So today we've covered the initial and follow-up forms for observing interns or BHCs in their clinics and the intern clinic summary form. We've covered the rating system for each of the sections and how providing concrete feedback after their clinics can help improve the skills of interns and BHCs over time. Integrated care is still a relatively new field in psychology, and making sure that we have something that can create a standard set of skills is vital to the profession. We're not here to create robots and make everyone the same, but provide a standard set of skills at which they can put their own style around, if you will. CHCW is on the forefront of creating training in the primary care behavioral health model, especially with the most recent edition of our intern program, which spurred the creation of these forms. So as I mentioned before, this can be used with interns or BHCs who are entering the field, or BHCs who have been in the field for a long time, as we are all still constantly training, trying to upskill each other every day so that we can continue to provide the best care we can for our patients. Hope you enjoyed this video and found it useful. Thanks for joining us.